Make sure this is starting. All right, good afternoon, everyone. How's everyone doing today? So welcome to July's 2016 Coder Development Program session. We're blessed to have Dr. Penny Castellano with us today to talk about everything and anything related to macro and population health management. So just a quick introduction. So Penny Castellano, MD, she is the Chief Medical Officer of Clinical Operations, Chief Quality Officer for the Emory Clinic and Emory Specialty Associates. She's a Professor of Gynecology and Obstetrics, Vice Chair for Clinical Affairs in the Department of Gynecology Obstetrics at Emory University School of Medicine and continues a clinical practice focused on menopausal medicine. Her current responsibilities include a focus on quality of care and patient safety as well as clinical outcomes operations, including the use of electronic medical records in practice. Dr. Castellano received her Bachelor's of Arts degree from Drew University in Madison, New Jersey, her medical degree from Emory University School of Medicine, and completed her residency and training in gynecology and obstetrics at Emory University affiliated hospitals. Since joining the faculty, Dr. Castellano has served as the Division Director for Primary Care Obstetrics and Gynecology, Residency Program Director at Crawford Long Hospital, Section Chief of Primary Care Obstetrics and Gynecology, and Chief Medical Officer for Primary Care. So please join us in welcoming Dr. Castellano to Coder Development Program.
Thank you so much. I think that officially makes me an hemorrhoid.
Yes.
I think, among other things. So let me know if can you hear me okay, because I'm going to try to use the mouse as we're going here. So Hassan asked me to try to give an overview of macro MIPS and then to show some examples of how this sort of impacts us as providers when we're trying to document things and figure out what little codes we should put on the claim so that the insurance company or the federal government knows what we did and how sick the person was. So I'm going to try to do a pretty fast overview of all this. I've got a test patient open in PowerChart, so if there are questions about what it really looks like live, we can go there if we need to. So let's start off. Down arrow? We'll just do that little arrow there. There we go. Okay. Let's start off with the whole, this is a very high level overview. This is the piece of reality that got us 892 pages of regulatory beauty in the last couple of years. But this is the whole reason why MACRA exists. So when you look at the way that we've been doing healthcare for the last 15, 20 years, there have been some kind of awkward and not so nice realizations. Back in 2000, you may remember the Institute of Medicine released the To Err is Human report, suggesting that we kill close to 100,000 patients a year by medical errors. So that certainly is not anybody's intent. It's a reality. It's a reflection of the complexity of care and the fact that we don't all do things the same. Lots of opportunity to fix that, and we've been working on it for the last 15 years, but the work's not done. When you look at the cost of healthcare in the U.S., the cost, which you can see here, has been escalating for the last 25 years to the point that the way that the economics work, at least for the Medicare population, we will not have enough money to pay for all the Medicare recipients by 2028. And so we have to lower the cost per person or the cost per episode of care if we hope to cover the U.S. population the way that we've been covered for the last half of a century. And then of fairly recent realization was also from the Institute of Medicine in 2012, suggesting that for all sorts of reasons, fear of failing to find something, defensive medicine, lack of interoperability between electronic medical records, there's a whole list of reasons. But they're estimating that 1/3 of what we spend money on in healthcare isn't even necessary. So just think about the MRI that we repeated because we couldn't see the MRI from Keystone, the labs that we repeated because the patient came from California and did not bring their records with them. So lots of opportunity to reduce cost. And just to let you know that these errors haven't gone away, just in the last 3 months, the Institute of Medicine has re-released an error estimate, and it doesn't look like we've made nearly the dent that we need to have made. So, value of healthcare rather than volume of healthcare is pretty much where Medicare was sitting in 2015. How do we start to improve the value and stop inciting people to just do more and more of the same thing? So Medicare actually started back in 2007 with, I'll call it experimenting and dabbling at pay for performance or pay for value. There was something that was a demonstration project in the early 2000s that actually demonstrated that if you ask providers to write down whether or not they did the right thing, they tended to do the right thing more often. That was the sort of the launching pad, if you will, for this PQRS, Physician Quality Reporting System, whereby we were asked initially to report to Medicare by writing a code on the claim whether or not we did something. And the sort of evidence bore true that we did it more often if we were forced to write it down. So this was initially a program that ran an incentive to providers for reporting. It quickly turned into a penalty avoidance program. It became more complex. We began a group reporting method, and we're now required to report if we're in a group of more than 10 providers, and you report just to keep yourself whole on the Medicare fee schedule. There's a penalty for not reporting. So this was kind of percolating along. This was Medicare's very linear, very slow progress to value-based payment. And in 2015, preceded in 2014 by an almost SGR repeal, the federal government decided that the sustainable growth rate was no longer sustainable for adjusting Medicare fees. So remember what I said a couple minutes ago, there's only so much money in the bucket for Medicare. As the number of people who are Medicare eligible go up, you have to spread the money over more people. So the way that the accounting department for the government did this until this year was that they would say, okay, if we're going to pay $100 to have 1 million people in the Medicare bucket, that $100 for, let's say, a return patient visit, we can't afford to do that. There's too many people. So we'll drop it down to $90 for a return visit, and then we could spread the money over more people. Well, we had gotten in 2014 to a point where the Congress had never actually enacted that drop. They had been sort of saving it, hoping that one day they'd just implement it. Well, in 2014, the drop that we were needing to keep Medicare whole was a 25% fee decrease. So instead of 100, it was 75. And for lots of political reasons, the government decided, yeah, we can't go there. People will stop taking Medicare. Patients will have no access. That's a bad thing. So they did this thing called the Sustainable Growth Rate Repeal. They are no longer going to use that kind of math to make it possible for Medicare recipients to get Medicare benefits. What they're doing is they are changing all of the way that Medicare fees get paid to value-based instead of volume-based. So that $100 for a return patient visit may be $30 if you spend a lot of money on your patients and don't have very good outcomes, or it may be $120 if you have very efficient care and very good outcomes. So think about it as a value-based adjuster rather than a volume-based adjuster, which is what the SGR was. Does that make sense? All right, so this thing called MACRA, the Medicare Access and Chip Reauthorization Act, everybody laughs because it is the epitome of a federal government acronym because there's an acronym in the acronym. So we'll all quickly forget what all this really means, but think about it this way. This is requiring us to go to a value-based payment model by one of two systems. You either do something called an alternative payment model, which means that you basically function with Medicare for all of your patients the way that HMOs functioned in the 90s. You get a certain amount of money. You are expected to stay within that amount of money to take care of all the patients. If you go over, you actually may have to pay Medicare back. That's a new exercise. If you stay within bounds and actually improve and save Medicare money, they'll give you some of the savings. So when we say go at risk for Medicare, that's the alternative payment model, and that's the model we're talking about. A lot of folks, providers, large groups, especially academic medical groups, aren't quite ready to be at that level, and we'll talk about why in just a minute. So the default, if you do not decide to go at risk for your Medicare population, is something called MIPS. This is the Merit-Based Incentive Payment System, which basically takes all of the reporting that we currently do for Medicare, combines it into a single score. This is super calculus when you see the scoring system, which we will not go into in detail today, but it's a combination of PQRS, the thing that we get back from Medicare today called our Quality Resource Use Report, which basically tells us how much we spend per patient, meaningful use, and a yet-to-be-described clinical practice improvement score. So again, keep in mind that all of this is in something called a proposed rule that won't be official until November. So we know a little bit, but we don't know all the details and won't until November. But basically, this score, your score on MIPS, will be factored into a modifier on your Medicare fees. So not a whole lot different than what we were doing before with PQRS. It's just now it's kind of uber PQRS. It's got all the stuff together and it's one big score. So both of those methods, whether you do MIPS or whether you do an alternative payment model, it causes us to start thinking differently about our patient population. So what Medicare would like us to avoid is having, let's say, a diabetic. That's such a good example. Because diabetics, by and large, need a lot of care during the year to stay healthy. And our goal in taking care of a diabetic is to keep them from getting any of the end organ complications that you can get from poorly controlled diabetes. So poorly controlled diabetes can lead to problems with your eyesight, with your kidney function, with the way that your nerves and your limbs work. So our job is to not let patients have any of those end organ repercussions of diabetes. So how good do you think we are at that when we see a patient for 15 minutes 3 times a year? We're not very good. So when you look at population management and this value-based payment system, what they're actually asking us to do is to start being responsible for all of the patients who are, their language, attributed to us. We've either already seen them for primary care or key specialty care, or they're in a kind of an arrangement where they've selected us as their healthcare provider, like an HMO kind of a thing. So we have a list. Sometimes we actually get the list before we get graded. Sometimes we don't get the list till after we get graded. But we have lists of patients who have chosen us one way or the other. They've either seen us or they've put us on as their provider. And just about every healthcare population can be divided up similarly. You have a fairly large foundation of healthy patients. They occasionally have a cold, the flu, may get a bladder infection or fall down and break a limb. They don't need you other than for those little acute episodes. Then you have and this is usually the majority of your patient population, a patient population segment that we call at risk. So they may have blood pressures that are creeping up, but they don't quite have hypertension yet. They may be overweight, but they don't have diabetes yet. They may have had a couple of minor illnesses that cumulatively have caused them to need special care, but they haven't become in need of chronic care yet. So we call that the at-risk patient population. And our job in population management is to keep that at-risk population from becoming rising risk or high risk. Your rising risk population, those are the patients that may have one medical condition, like high blood pressure. They haven't gotten heart disease yet. They haven't had a stroke. So again, our job is to keep them from moving up. And then your high-risk patients are your multi-comorbidity patients. The patient who has hypertension, had a stroke, has heart disease, now has heart failure, and we run the risk of them going in and out of the hospital way too often because we're not optimizing their care when they're out of the hospital. So when you get into population health, you are really tasked to start taking extra care of your high-risk patients, touching them if needed every day, at least by a phone call, to make sure that they're on their meds, they don't have a problem getting to an appointment, they haven't had a subtle change in their symptoms that we could do an intervention on and keep them from going to the emergency room tomorrow. These rising risk and at-risk patients need care plans. How are we going to keep the diabetic from getting a complication? How are we going to keep the hypertensive patient from having a stroke? And those care plans have to be agreed upon between the patient and their provider and then followed on a regular basis. And the key in all three of these patient populations is that we are actively providing care even when the patient isn't in front of us. So 15 minutes 3 times a year is no longer the method. It may be 15 minutes every week, only occasionally with the patient in front of you face to face, but with a lot of interaction going on to make sure that the patients are following those care plans, because our whole goal is to keep them from rising upwards in that pyramid. So does that make sense? All right. And then a particular challenge for us will be to be as fast as a minute clinic on all these patients. The parking on Clifton Road would be a specific challenge today, I'm afraid. All right, so what are we expecting to see across Emory Healthcare as we are positioning ourselves to succeed in either one of these branches of MACRA? Well, we have to structure ourselves for population management. We're really good at 15 minutes 3 times a year. We're not particularly great at touching a patient every week. So you'll see that we are moving in our primary care practices to this methodology called patient-centered medical homes, where part of the work of the practice is to see the patient face-to-face, but there's a segment of work every day that is that outreach to patients. Did they get their radiology studies done, get their labs done, take their medicines? Things like having a pharmacy send an email whenever a patient refills a prescription, that's what happens in medical homes. So that if you didn't get the note that the patient refilled his or her chronic med, or you got a note that the patient missed a refill, you're reaching out to that patient 2 days later, not waiting until 3 months later when they come in and their blood pressure is out of control again. So that work is ongoing right now in the Emory Clinic and in Emory Specialty Associates. What you may not have heard a lot about is the value acceleration projects that are going on, starting with the inpatient world. And what we're looking at in the inpatient world is trying to figure out who is doing best practice. So you take anything that happens in healthcare, there's always going to be some variation. Some patients are having no complications, some patients are having some. Some providers are getting their patients out in 3 days, others in 5. We are doing lots of deep dive work to figure out, is there a best in class recipe for doing all sorts of different kinds of care? Bowel surgery, taking care of a patient with sepsis, dealing with a patient who has chronic obstructive pulmonary disease. We believe, and our peers out there across the country have actually helped to prove, that there are best practices based on your patient population, the culture, the part of the country that you're in. We are doing that right now. We're trying to standardize where we can and make sure that everybody is getting the same best-in-class treatment. Across this is actually the Emory Clinic, but keep in mind that this is going to span both inpatient and outpatient pieces of the Emory Clinic. We are actually in a federally funded initiative to accelerate some of the work that I just described in the Value Acceleration Project and to start eliminating some of that unnecessary care. Lots of different ways to go about that. And then just so you know, because MACRA is such an overwhelming concept, and it is regulatory, and unless they bail out and say it's going to wait a year, it's probably not going to wait more than a year. But it's coming. There's no way that the federal government can continue to do what they're doing with us costing what we're costing to the U.S. population without them changing the method. So in March, when MACRA really sort of became a topic of discussion, Dr. Lewin and the leadership at Emory Healthcare stood up a MACRA response team for Emory Healthcare. And we had several of us as sponsors, and what you'll basically see is a fairly linear march around first education. What is MACRA? What are all the pieces that we know today, and what do the options look like for Emory? What are we going to do? Are we going to do an alternative payment model? Are we going to live in the MIPS reporting world for a few years? What would our timeline be for jumping to an alternative payment model? What will we have to do to succeed at MIPS? If you're going to report, you've got to report good things. You don't want to report that you're doing poorly. If you're going to do an alternative payment model, you actually have to demonstrate that you can take better care of patients for less money. So in either case, we know that we will have work to do, and we're defining some of those gaps right now. And we've done some financial modeling. What our team has recommended to leadership as of about a month ago is that we did not think that we were positioned well to do an alternative payment model strategy in 2017. So the way that the proposed rule is sitting out there right now, all of this starts on January 1st of 2017. You either start getting measured for reporting to MIPS, or you start figuring out how to succeed in an alternative payment model being paid that way on January 1st of 2017. We did not think that we were positioned well to do this, the alternative payment model, in 2017. And basically the reason for that links back to provider-based coding. So those of you who have familiarity with what we did in the hospital setting, about 5-6 years ago, we went on a crusade that is now known by the abbreviation CDI, for Clinical Documentation Improvement. We brought in a team from 3M to start doing real work on coding. And what they did, and what our nursing staff still does, is they actually read the provider notes. And they look to see, did you actually code for everything the patient experienced and everything that you took into your medical decision making? So a good example of how that has helped us in the hospital, let's say that you've got a patient who's admitted for an appendectomy. And in the course of the appendectomy, you realize that the patient is anemic, reproductive age female with heavy menses. So she's anemic. So we've written in the note low blood count. We haven't used the word anemia anywhere. So the coders in the hospital can't actually extrapolate from low blood count to anemia. And so the anemia code is never used in the bill. If the anemia code had been used, we would have gotten an extra day on length of stay and not gotten a penalty. We would have gotten paid more money because we had to manage the anemia, and the patient's risk category would have gone up with her payer. We didn't code anemia, so the payer has no way to know that this wasn't just a normal, healthy 28-year-old who came in for an appendectomy. So what happens in the hospital setting is that when patients get discharged, the staff goes through the note, makes sure that we have connected the dots on anything that's commented on as a complication, as a risk modifier, as something that's a comorbidity for the patient. All of those things get coded in correct hierarchy fashion. And then we then feel like we have adequate and accurate adjustment of the risk for the patients who are in the hospital. Compare that to what happens in the outpatient world, which is by and large, I'm going to show you the workflow, a doc, a computer, a patient, and 15 minutes to do everything. And I will tell you that my 2,000 best friends pretty much say the same thing. I pick a code. I don't have time to sit there and figure it out. I pick a code. So let's spend a couple of minutes kind of looking at actually what we do when we're at the sharp end of patient care. And I'm going to skip over a little bit of this because we've already talked about it, but alternative payment models, one of the keys to this, and the reason that we didn't think we were ready for this year, is that they decide what they expect you to spend on your patient population based on the risk that they already know you have. So what I just told you is that we're just picking a code. When you look at our whole patient population as we know it today, 90% of the patients never touch our hospital. So they haven't had the benefit of those CDI nurses. It's a doc, a computer, a patient in 15 minutes. So we're picking a code. So when Medicare looks at how much we spend, they will have an expected spend rate based on a very low acuity patient population, because 90% of our patients haven't been in the hospital, and you've got a doc picking a code. And then they'll have an observed spend. So we will spend what we spend taking care of these patients. And Medicare is going to very likely look at it and say, wow, we expected you to spend $2 million and you spent $4 million. So now you owe us money back. So we didn't think that that was a good position to be in when you start an alternative payment model. So we said, you know what, we need to work on our coding and our risk stratification to make sure that it's accurate. How do we know we have a bit of an issue? Although 90% of our populations never get into the hospital, when you look at Emory Hospital, the acuity score for our inpatient service in the hospital is like 95 plus. We are one of the sickest patient populations in the country. Most of those patients do get seen in the outpatient world, although there are a lot of patients outpatient that never get admitted. Our acuity score, as we reported to Medicare, this is based on what we put on the claims, is in the 78th percentile. So we know we've got room. And so we really feel like we need to spend a year dealing with that accurate reflection of the risk of our patient population. So that defaults us into MIPS. So we're going to be reporting. And in our MIPS calculation, the one thing I want to point out here is that in our first year, you see that we're going to get a lot of quality feedback. So we'll get most of our score based on quality. All 4 of the components we discussed all calculate in, but the majority is quality. By the 3rd year, the majority is resource use. So there again, our observed cost to our expected cost is all determined whether or not we succeeded based on the risk of that patient population. And this is just a brief overview of how we're going to be reporting, and I just want to point out the one reality. We get to send in a report for PQRS. We get to send in a report for meaningful use. We have no idea what that's going to look like yet. And we're going to have some method of reporting that we've done practice improvement. Again, we have no real idea of what that is going to look like yet. On our resource use, the only thing that Medicare sees is claims. So it doesn't matter what the note says. If it's not on the claim, they can't count it. Okay, so on to the workflow. Okay, so I've got a couple of just screenshots here of what it looks like from the provider end when we're doing one of our visits. So for Medicare, you get a sort of double opportunity to get the risk scores right. When patients first come into Medicare, they are encouraged to do a visit called a Healthy Start visit. And what the Healthy Start visit is really geared to do is to put you as the patient in front of a provider, doesn't have to be a doc, but that provider is going to figure out all of the comorbidities and risk that you have and put it into a note and code it appropriately so that Medicare can then grade you as the patient. Okay, you're risk level 1, 5, or 10, depending on what is on that claim. So in PowerChart, and I'm going to show you this on the note that's actually built to do this, there are a couple different ways that providers document, but these annual wellness visits are done by primary care, and they're almost always done in this particular Power Note. So you've got a patient in front of you, you open up the note for annual wellness. And the first thing that happens is that the note pulls in a problem list. And based on what's on that problem list, you may or may not get the whole picture of the patient. So there's an opportunity right in the first couple of frames of working with the patient to go to the problem list and see, are there things in addition to this little subset of active problems that just pulled in that I should know about or add? So just having a discussion with the patient. Have they been diagnosed with something new? That's something that can be added. Do they have a chronic condition? Maybe they tell you they're seeing the rheumatologist. Well, why are you seeing the rheumatologist? Oh, I have gout. Oh, well, great, that's not on the problem list anywhere. So there's an opportunity right at the beginning of the visit when you're taking the medical history to start to think through what's missing from my patient's problem list. How am I going to get that into the note and onto the problem list as I'm meeting with the patient? Then as you are doing an annual wellness or a Healthy Start visit, there are a lot of reminders and some things that pull forward, procedures that the patient has had. So if you see that mastectomy is listed on the procedure list and history of breast cancer is not, another opportunity. You may see all sorts of surgical procedures because they pull directly from our CPT coding. We don't have the same kind of pull for the problems. We tried that and it ended up really messing up the patient problem lists. So the problem lists are still provider keystrokes, but there's a lot of opportunities to miss things because we're relying on provider keystrokes. So again, clues, talk to the patient, get their history, look at the procedures that they've had. And then in a Medicare wellness visit or a Healthy Start visit, there are tons of scores that are to be derived for patients. So scores like, have you been depressed? Because that is something that changes your condition. Can you take care of yourself? Can you make your own meals? Can you bathe yourself? Do you live alone? Do you need help with your daily activities? Again, all of these are scored in a very discrete way. And there are actually numerical scores that come out on the other end of the note that let us know, does this patient qualify as being at risk? Fall risk. Have they fallen? Do we need to prevent falls? Do they need special help? Does somebody need to go to the home and check on their furniture, their throw rugs, etc.? So tons of screening. And then anything that is a gap in care. So in my world, I see a lot of menopausal patients. The patient who didn't have the bone density, who's got the osteoporosis that we don't know about, who's got the fall risk because there's steps in her home that she can't navigate well because of her gout, that right there is a disaster waiting to happen because now she's got a hip fracture and now she's in the hospital. So I actually get extra credit if I figure out that there's osteoporosis because I did the bone density, I treat the osteoporosis, and I send someone to her house to keep her from falling so that she doesn't end up with that hip fracture. So that's what Medicare is trying to get us to do. Just understand this is a lot of stuff to try to navigate through in 15 to 20 minutes. So that's really sort of the work of the provider. And then the real key, as they hand off the work to their care team, so those people who might be calling the patient once a week, once a month, just to make sure they're getting it all done, is whatever goes into the part of the note that is called the plan. Am I going to give the patient meds? Am I going to do any testing? Let's make sure the patient gets the meds, gets the test. Are we going to touch the patient and how often? And then when am I going to see the patient back, or when is my care team going to see the patient back? So that's really what goes into a medical annual wellness visit or Healthy Start. You're creating a really accurate picture of the patient's risk. You are looking at ways to mitigate all the risks that you find, and then you're putting together, this is a magic word, a care plan. And once you have a care plan, and it really is outlined, the patient's going to do A, then B, then C, then come back, then your team can start to monitor the patient's adherence to the care plan. And oh, by the way, those once-a-month phone calls to make sure the patient's actually getting things done is a billable service. So that's where Medicare wants us to go. Now, in my world, I'm not doing primary care and I'm not doing an annual wellness visit. I usually, when I go into a chart, I look to see if somebody's done that for my Medicare patients. And I'll see a note, and it'll say annual wellness visit at the top, and there'll be a lot of these scores and a lot of this care plan stuff going on. That's how I know something good has been happening. If not, of course, when I see my patients, I will tell them, make sure you get to your PCP to get this stuff done. But when I'm doing my note, I'm seeing the same sort of thing. I'm looking at problem list. I'm looking at what the patients had done elsewhere in the system. I can see those same procedures. I'm, again, even as a specialist, going to start trying to connect the dots. I see mastectomy. I don't see breast cancer. Something's wrong. I see that you were treated with anticoagulation for something. I don't see a condition that warrants that. So let's talk. Let's add things to the problem list. And then as I finish up my visit, I'm doing the same thing as my colleagues in primary care at the wellness visit. I'm making sure that I've looked at the things that require my attention, things that are in my medical decision making. So let's say that I have a patient who's menopausal, who has breast cancer. I need to make note in my explanation of how I manage the patient that I took into account the fact that she had breast cancer, because it's going to change the way I manage her. So now I get to put that in as one of my diagnoses that I used. Let's say that she had a blood clot and was on anticoagulation. That's going to change all the things that I can offer the patient as far as medications go. So I'm going to need to comment on that and bring that diagnosis in. So what I'm doing this part here where I'm looking for diagnoses, I'm actually toggling back and forth between the problem list and my note, trying to make sure that I've captured the right problems. It's not that hard to add a new problem, but you want to make sure that you've got listed in your note and on the problem list a matching set of things. There may be more on the problem list than I can put in my note. I'm probably likely not going to put an ophthalmology problem in my note, but it's good to know that it's on the problem list and to at least be aware of it. So then when I'm done, I get a note that sort of looks like this as well. And some of our colleagues, about 60% of the clinic is doing this other note writer, where you see it as side by side. Whether you see this long column-like note or side by side is just a matter of which note writer they used. You should always be able to find the problem list and procedures, and at the very end there should be an assessment and plan, and that assessment should include all the diagnoses that that provider is claiming for the day. So I'm finished with all that, and now I'm going to help your team figure out what I want to bill for this patient. So I go to a screen that has a bunch of orders on it. And everybody does this sort of in their own little way. I'm pretty methodical. I have the labs I'm going to order, the radiology I'm going to order, and then how I'm going to bill the patient. And everything that I've put in as a diagnosis comes up on this grid. And what I need to do as I'm trying to figure out the reasons for the visit is mentally think about, okay, what were they here for? That's my number one code. And then what else did I manage? So then I'll go from 2 to 3, and I do it pretty much on how much of my thinking time was spent on each one of those problems. And then if there's something really remarkable in their family history or their personal history, that will be like number 6 or 7. Sometimes I get to number 10. It just depends on how complicated the patient is. If in the process of doing all of this, I realize, oh, there was another thing that I didn't actually put down, I can click on this little, it won't do it here. See, I think I'm in live power chart. I can click on this, and it'll allow me to add another diagnosis. But this is a lot of clicks. And when I'm all done with this, I hit sign, and this thing on the bottom becomes the charge that you all see print out. So does that make sense? So I just did those descriptions of the note writing really fast. It's usually not quite that fast. Some of us have a lot of things that are shortcuts that help us write the note quickly. Then we all have Dragon, so I can actually speak into a little microphone and it types for me. That's really great. Some days Dragon just stops working. Some days Emer just is slow. Some days I get kicked out mid-thought and I have to get back in. So when you hear providers talk about, I'm trying to give you everything I can, but it's all I can do to just put down upper respiratory tract infection and not worry about the rest of it because I really just took care of the upper respiratory tract infection, that is it's a little bit of a dilemma for us as providers. We frequently don't realize what goes into our medical decision making, and we are way too chicken to actually say it out loud. So we just say, I know that was a transplant patient who has leukemia, who just got out of the hospital last week, but he just came in for an upper respiratory tract infection. I didn't take care of any of the rest of it. If you had to think about the rest of it, if it modified the way that you treated the patient, if it modified what you ordered, how much time you spent, or how you counseled the patient, not only can you, but you should put it in. It's a matter of how many seconds can I spend clicking on this stuff and making sure that I search for the right code and that I put it in the right order so that I can hit sign and it can go out as my bill. So that is what we are dealing with right now in the ambulatory world. And just to make it a little bit more exciting, we all did this ICD-9 to ICD-10 thing last year. So what we now know, and I guess we kind of understood this last year, but it's much more in our face now because of the possibility of doing these alternative payment models, plans for Medicare, is that in addition to ICD-10, there's the double secret codes. These are the HCC codes, the hierarchical condition codes. So not every ICD-10 walks over to similar HCC codes. So there's, I don't know, 40-something thousand ICD-10 codes. There's not that many. There's a couple hundred HCC codes. And if you look at the, I don't think I have a screenshot of diabetes here. No. If you look at the crosswalk for diabetes, you may see that there are 50 some odd codes for type 2 diabetes. There's only 3 or 4 HCC codes, and not all of the type 2 diabetes codes get you to an HCC code. So it is possible, as you are trying to do this work really fast in between patients, because they're all backing up in your waiting room, that you could pick the ICD-10 code that doesn't actually have an HCC score. And the way that Medicare figures out the expected spend is on the HCC scores that accumulate over the course of the year. So if you do this wrong, Medicare thinks you should spend $100 when really you should be spending $500 because the patient's much more complex than they think because of the code that crosswalked from your ICD-10 code. So that probably just made you dizzy. It makes me dizzy saying it. But that's actually how it works today. And so we know that we have a lot of opportunity on helping providers code. In the hospital, providers don't code for themselves. Coders code. You all know how many patients we see across the Emory Clinic in a day. There is not a chance that we will be able to hire coders to code the 1,500 patients an hour that we see. So we've got to figure out, is there a subset that we need to relook at? Is there a set of tricks that we should be educating the providers to implement as they are doing this work? Are there little cheat sheets that can be a part of the electronic medical record? We think so, but none of the electronic medical records have gotten that sophisticated yet. So that's where we are. We've got a lot of learning to do. We're going to be trying to leverage all of what I just shared with you over the course of the next year, because we want to report well on MIPS. We want to make sure that even if we are not in an alternative payment model year one, that folks give us credit for taking care of the patients who are as in need as they are of care. We don't want to shortchange a patient, but we also want to make sure that Medicare really understands what we're doing in an accurate way. So that's all I have slide-wise, and I am happy to take questions, anything that I can do to help. We'll start with Babs, and we'll just go across the room.
Has this presentation been done to primary care and medicine?
Yes. So I hear what you're saying, but let me now just paint the scenario. Oh, yeah. Yeah, so Babs wanted to know whether or not this presentation has been shared with primary care. And I said yes, and she said, well, they don't hear very well. And I understand that perspective, but now let me share with you the perspective of the provider who has a 15-minute appointment slot. The patient starts off the visit, and I'm going to tell you, this happens to each one of us every day. The patient starts off the visit in tears because something happened at their house. They got a bill that they couldn't pay. Something broke that they can't fix. They fell because the steps are degrading and they don't have the right person to fix their front steps. That's 3 minutes. Now you're going to try to take a medical history, calm the patient down, take the medical history. They have 3 or 4 new things to report. So you have to actually figure out what kind of pneumonia did you have. Were you an inpatient? Were you an outpatient? Did you get IV antibiotics? How long did it take you to get better? Who are you seeing for pulmonary for follow-up? Oh, at DeKalb. Great. Okay, now I don't know who that person is. I can't see those notes. So this is going on. You still got that 15-minute window. Then you got to examine the patient. Then you got to walk out of the room, or in the room. Some people do it in the room. You document what just went on, because the worst thing that can happen to you as a provider is to let the notes stack up, and at the end of the day, you can't remember whose lungs sounded like what. So the rule of thumb is that the physical exam should always be documented as you are getting out of that patient visit. Then you go out into the hallway, or you're sitting at the desk, and your nursing staff is standing behind you. You are 15 more minutes behind. So-and-so in the waiting room's got to be in ophthalmology in 20 minutes. What do you want me to do? And you're trying to figure out which ICD-10 code crosswalks to which HCC code, and what did you use in your medical decision making. So I hear you, and I just want to share how hard this is. None of us want to be doing as poor a job as we're doing, but everybody has their own special method, and I tell you, it's a bell-shaped curve, and there are a lot of us who aren't catching all the codes every single day. I think you're right. So Bab said the annual wellness visit, people don't understand what it's for, and I think you're right. I think that this train has been going so fast that we haven't gotten people to catch up, and in a way, they're saying that that Medicare may hold off a year on macro, that they may say, like ICD-10, oh, we mean it, we mean it, we mean it, just kidding, we'll wait till next year. If they do that, that actually gives us more time to get people more comfortable with the vocabulary. 5 years ago, we didn't even have the term annual wellness visit. So it's now a real part of what we do, and I think that a little bit more time wouldn't be a bad thing. Yeah.
Well, last year I took focus on Medicare. And one of the questions that came up that they were asking how we talked about is what happens or how do we prevent getting penalized for non-participation?
Yes.
So did they come up with an answer?
No. Well, they have an answer, but it's not the one you want to hear. So if it is your attributed patient, you are on the hook. You are on the hook. And I don't think any of the benchmarks will ever be 100% or 0%. So no one's ever going to expect us to have 100% of our patients not smoke or 0% of our patients miss a flu shot. So I think that's sort of how Medicare kind of gives you a little bit of room to slide. And as part of our decision as we think about how we want to approach MACRA, if you are in an alternative payment model type of plan with Medicare, you know at the beginning of the year in some of those plans who your patients are. The way that we live now, we don't know who we're going to get graded on until the year is over. So if you know the list of patients you have at the beginning of the year, you can at least in a finite fashion say, here are all the patients who should have done X, Y, Z. These 5 are missing. Let's go call them. Let's send them a letter. Let's see if we can do some outreach. The way it goes today, we have somewhere around 17,000 Medicare patients, but we don't know which ones are assigned to us until January of the year following our grading, which is, to me, that's kind of unfair. That is correct. Yes. That's actually very important. When you look at all of the ICD-10 codes that are available, there are a lot of codes that we don't know we should be using. And so we look to those audit exercises that you all do when you're reading our notes to help us, oh, in my specialty I can actually code for forgot to take birth control pill. I mean, that's a code. And so to be able to know that, none of us have had enough chance to really understand everything that's available, even in ICD-9, let alone in ICD-10. And I'm sorry, your question was?
Will they will they equal one of those points and
Oh, the HCC? Yeah, so usually things like non-compliance or needed screening because of high-risk behavior, I don't think that those get you very high HCC scores at all. Sorry. Probably one of those robocallers. Happens about the same time every day. Yeah. So really those HCC scores, and if you look at, this is just a very brief list, and I don't think I can make this any bigger on here. But these are things like has diabetes and nephropathy, had a stroke and it has weakness of a side or quadriplegia, had a major depressive disorder and needed to be treated, major head injury. So these are really there to denote the sickest patients, but here again, we have primary care docs seeing patients for UTIs and upper respiratory tract infections, and the patients have some of these conditions, and we don't ever tell Medicare all year long. And so there again, we may have done extra hoops to make sure that that patient got the right care because, oh, we forgot to say, she's wheelchair bound and can't get to the lab on her own, so we had to go through these extra hoops. We'll get credit with the patient for doing the right thing, but Medicare won't recognize that we did it. Yes, Eric. Mm-hmm. Mm-hmm. Right. Yeah, so so I think it's if you code accurately, which is work, you should not have to defend medical necessity because it should have been the right thing to do. One of the things that that is part of that federally funded program that we're doing, this Transforming Clinical Practice Initiative program, is that we are implementing decision support in the ordering system that will help providers actually tell the right story. So we get scored, last year was our first year, against other faculty practices on the rightness of what we're doing. It's a quality and accountability scorecard. And we didn't score too great last year on the use of advanced imaging, so CT scan or MRI, for simple headache. So we actually pulled the data that the scoring entity used, and we had residents go in and do chart reviews. And one of the areas that we realized was a huge opportunity, when patients come into the ED with a headache, they're almost never there just because they have a headache. They're there because they have a headache and can't see. They have a headache and they're nauseated. They have a headache and their blood pressure's 250 over 140. We put on the MRI order headache, and it looks wrong. So this was an aha just 2 weeks ago. We really need to do a better job of coding the right thing. So as we're working with this decision support vendor, the plan is that when I go in to order an MRI for headache, if I don't have another code to accompany headache, it's going to give me a little pop-up that says, hey, you're ordering advanced imaging for a simple headache. Is there any other reason you want to do this? Because here are a couple of thoughts. And so when you have a coding issue, the good news is that you can actually remind people to figure out the way to do it correctly. Our biggest concern, and I'm happy to report that we have not found this yet, is that we have a care problem. So what you don't want is for people to say to you as providers, you know, I know a guy who got sued in Florida for missing XYZ, so I do MRIs on everybody. We have not seen that. That's the good news, is that I think our providers are incredibly evidence-based in the way they practice. It's this nuance between don't send this back to me because it's not medically necessary and I only got 15 minutes and I just had to do all the rest of the stuff, so I'm just going to give you a reason so you know what to look for. Other questions? Other comments? We are at time pretty much, so I'm happy to just stop. Happy to stay here if you want me. Thank you all very much. Pleasure to be here.